Good afternoon. I'm Cindy Hall, president of the Women's Congressional Policy Institute. It's great to see a full room today. Welcome to this afternoon's briefing on chronic pain in women and its relationship to opioid abuse. The Women's Congressional Policy Institute, or WCPI, as many of you know, is a nonpartisan, nonprofit public policy organization, and our mission is to bring women policymakers together across party lines to work on issues of interest to women and their families. And we work very closely with the Women's Caucus and their staff and members, and we would like to thank our congressional briefing co-sponsors, including Congresswoman Susan Brooks and Congresswoman Lois Frankel, who co-chair the caucus together, Congresswoman Mimi Walters and Brenda Lawrence, the vice chairs of the caucus. This is the 12th briefing in a women's health series we are sponsoring over several years, underwritten by the Robert Wood Johnson Foundation. And it will be the first of several briefings we will be holding focused on opioid use disorder this year. We thank the foundation for its support and its work to improve health and health care for all Americans through its support for research and programs working to build a national culture of health. Our thanks to our esteemed panel of speakers, Dr. Nora Volkoff and Dr. Jerome Adams, each of whom will be introduced shortly. And I also would like to acknowledge Amy Plaster, WCPI Board Chair. Where is Amy in the room? Back there. And also Dr. Irene Trowell-Harris, who's the former director of the Center for Women Veterans at VA. We are thinking about doing a briefing focused on women veterans and opioids, so please stay tuned for that. That's coming in the fall. This briefing is being videotaped and should be available for viewing early next week, so please stay tuned for messages about that and let your colleagues know who weren't able to join us. We will be live tweeting during the briefing, and we encourage you and others to do so using the hashtag WCPIHealth. And then one final note, there are green survey sheets in your briefing packets. If you can take the time to fill them out, ideally leave them as you leave at the registration desk. It helps us to get your feedback both about potential topics for briefings, but also how we might make this series better. And so I am now pleased to introduce Congresswoman Lois Frankel. And as I mentioned, she's the Democratic co-chair of the Women's Caucus, serving her third term representing the 21st District of Florida. She serves on the Foreign Affairs and Transportation and Infrastructure committees and has been a strong advocate for women's health, veterans, seniors, and families. And in regard to this issue, has been particularly concerned about the epidemic in Florida in her district in West Palm Beach.
Thanks, Cindy. We got it, okay. All right, first of all, definitely you need a lower podium. Or something, does anyone see? I do have more than a head, okay. Hello, everybody. Thank you for being here. And Cindy and Cheryl, thanks for the great job that you do. Women's Congressional Policy Institute it's bipartisan, right? And the issues we cover really don't know a party, as drug addiction knows no party. So I want to welcome Dr. Volkow and Dr. Adams. I'm looking forward. I'm going to sit through this because this is a big crisis in Florida, this drug addiction issue. So I'm going to just start with a personal story, which is pretty inane, I will have to say. But I'll tell you it anyway. So I was once I was mayor of my city, and I was in this contest called Dancing with the Stars. And I had to practice for months, and my partner was like this tall, and so when I show you this, it's painful to me. So I had to dance like this. And by the time we came to the competition, my shoulder was in so much pain, I am telling you, I would have done anything to stop that pain. And I said to myself, oh my goodness, if I had access to drugs, I would take them, right? Well, I took 6 Advil that night to get with the dance. But I think everybody here probably has experienced at some point pain that is so overbearing that you wish you could do something to relieve it. It was a young lady in my district where I live. Her name is Tasha, who graduated from high school. She was with honors from one of our high schools. She was inspired to be a medic, so she joined the Army to be a medic. Eventually was discharged. She had an injury and then a car accident, which led to really chronic neck and back pain, and she was prescribed painkillers. This is a common story with that contain oxycodone, and it just spiraled out of control. And by age 33, she was dead. Unfortunately, I know where I live, this is a very common story because we're finding people who overdose, young people, literally in the streets. So this is not necessarily a criticism of her healthcare providers. I think they were at that time. They were trying to relieve her pain, and what it led to was addiction, and then her own death. So this is a very, very timely session. I thank you for it. I thank my colleague Susan Brooks. I think she'll be here in a few minutes, and thank all of you who are here. And I hope you're going to spread the word. I look forward to our conversation. Thank you again, Cindy.
Thank you, Congresswoman Frankel, and thank you for all you're doing on this issue and so many other women's issues. It's a pleasure to work with you. I'm now pleased to introduce Dr. Nora Volkoff, who became director of the National Institute on Drug Abuse, or NIDA, at the National Institutes of Health in May of 2003. NIDA supports most of the world's research on the health aspects of drug abuse and addiction. Dr. Volkoff's work has been instrumental in demonstrating that drug addiction is a disease of the human brain. As a research psychiatrist and scientist, Dr. Volkoff pioneered the use of brain imaging to investigate the toxic effects and addictive properties of abusable drugs. Her studies have documented changes in the dopamine system affecting, among others, the functions of frontal brain regions involved with motivation, drive, and pleasure in addiction. She has also made important contributions to the neurobiology of obesity, ADHD, and aging. Dr. Volkoff.
Thanks very much. Good afternoon, everybody. And I want to thank Dr. Cindy Hall for inviting me. And I think it's the third or fourth time that I'm participating in these events. I also thank very much Congresswoman Frankel, and I'm honored also to be here with my colleague, Dr. Jerome Adams. So, and it is to speak about a crisis like I've never seen, and when we've never seen in our country as it relates to drugs, or many actually comparable to some of the worst healthcare crises that we've been facing. And in this case, it's the opioid crisis. And so I'm going to be speaking on at two levels. One of them, the opioid crisis in a general term, but the other one, what is unique about the opioid crisis as it relates to women. And so I would just start by saying what is notable about this opioid crisis, and I would say three things jump into my brain. One of them is the number of people that are dying. So in 2015, there were 33,000 people that died from an opioid overdose. And that doesn't count people that die from other complications from the use of injection of opioids, like it can result in infections that can kill the patient, or the consequences associated with neonatal abstinence syndrome. So the impact in the healthcare system and in mortality and in economics is gigantic and unprecedented, number one. Number two, very, very notable, this is a crisis that was born out of the healthcare system. And as someone that belongs to the healthcare system, it is clear in my brain that we need to recognize that, because if we want to revert a crisis, if we want to contain it, and importantly, if we want to prevent it from ever happening again, we need to change the practice in many levels and the structure by which we are doing healthcare as it relates, number one, to the treatment of pain, and number two, to the treatment of substance use disorders, including opioid addiction. But number three is that this actually epidemic has affected a very vast set of individuals that normally and traditionally have not been associated with drug taking. And among those include women. And what's interesting is if you look at epidemiological data, over all of the patterns that you see in terms of drug taking and addiction, women have much lower prevalence rates than males. However, when we're dealing with the opioid crisis, and I'll show you some of the numbers, we see equivalent numbers between males and females. And in some instances, we see increased risk among females. And that increased risk among females, interestingly, is in part driven by biological differences that we have in terms of the way that we process pain. So here, this crisis has faced us to actually recognize the importance of the healthcare system in this problem and that they need to change practices and contribute to addressing the problem, but otherwise, we need to emphasize and understand what are the unique needs of women in order to actually solve the crisis. We cannot automatically transfer what we know on males into females. There are just too many differences in the process. So what about opioids? What is it why would people take them? Opioid prescriptions are predominantly utilized in order to actually address pain, very severe pain. They are extraordinary. If you've ever been in severe pain, and I have been, actually they give you an opioid and it's like magic. And when you are in severe pain, the distress is so intense that in many instances, if you don't treat as a physician, your patient can go into shock. So you need to intervene, and opioids can be life-saving when prescribed properly and for the indications that actually they should be prescribed for. But they also have strongly rewarding effects. And not every patient that gets an opioid can experience that subjective sense of well-being with an opioid. But if you have been given an intravenous administration or an intramuscular administration of opioid that are one of them, you'll realize how rewarding it is. And as a consequence of it, opioids are among the most addictive drugs of abuse. So, not surprising, what we're seeing is a shift on the pattern of drug use in our country. From the illicit substances, by far, marijuana is the #1 drug of abuse. But following it are psychotherapeutics. So Americans of all ages are actually starting to use medications that are used by the healthcare system in order to get high or for other purposes. And there are 3 classes that are abused. One of them, the most notable, is the one of opioid, pain analgesics. But following behind, very importantly, are stimulant medications that we use in order to treat attention deficit hyperactivity disorder that also can be highly rewarding and addictive. And following that are sedative hypnotics. And these are medications that we use to treat anxiety, to treat sleep disturbances. And they also can be highly rewarding and particularly problematic when combined with other drugs, such as opioids. And in fact, as we're looking at the number of deaths occurring from the abuse of opioids or from the use therapeutic of opioids, we're coming to realize that many of them are associated with co-administration of other drugs. And one of the important drugs are benzodiazepines, sedative hypnotics. So what is the reason why we are with opioids? What to understand about it pharmacologically? Opioids, whether you are taking heroin or you are taking morphine for pain or OxyContin, activate bind to the mu-opioid receptor system, and by doing that, they actually are able to inhibit sensations of pain. And so in that image, it's a real human brain, where you're actually measure the concentration of mu-opioid receptors, which are the target of these drugs. And you can see their location in different areas of the brain. And there in orangey look are the areas of the brain that are part of the pain network. So very important is that region called periaqueductal gray, PAG, the thalamus, the ACC, and the amygdala, which is not noted there. This constitutes a network that allows you to perceive the sensations of pain, but also the emotional reactions to it. And it's loaded with mu-opioid receptors. And if you get an opioid agonist, a drug like morphine or OxyContin, you will inhibit firing of these cells. And that's why actually it's such a powerful and such good analgesic. That's one. The other problem, though, the problem starts when you start to look at the other areas where these opioids are located. And in red, you have, or brownish, accumbens. That's the main reward region of the brain. And when opioids bind to it, when the opioids bind to the mu-opioid receptor, it activates, and that's extraordinarily pleasurable. And it can set in those individuals that have vulnerabilities the plastic changes that can result in addiction, like the story you just told you about this young woman who are receiving a pain medication, unbeknownst to her, had never had a history of addiction, but this powerful pharmacological effect activates a chain of events that can result in addiction. And we also have these receptors in the brainstem areas, which are someplace around here, deep, that actually are regulating our breathing. And we normally don't think about breathing. It's an automatic response. It's the default mode of our brain. But if you activate with very high levels of opioids, if opioids bind there, they inhibit those neurons, and you stop breathing. And that's actually the main cause of death in patients that are overdosing. So this actually led, this is at the essence, understanding the pharmacology at the essence of what happened. Very powerful medications for pain, very good intentions. Let's treat patients that are suffering from pain. And that led in the 90s to a very aggressive campaign to actually become much more active in treating patients with pain. So the prescription of pain opioid medications just skyrocketed. So why was that? Well, number one, it's a very good thing that we try to treat patients with pain, because if they are not treated, particularly patients with chronic pain, their outcomes are very, very poor. And suicide rates actually can be quite high in this population. But what were the problem? The problem were that we really didn't have a good understanding about opioids. We became complacent. We had experience with the use of opioids for acute pain, but not for chronic pain. Now, there's something very unique about the use of these drugs for chronic pain. You give them, and the more you give them, you need higher and higher doses. You become tolerant in order to get the same analgesia. So you start with a safe drug, and then without realizing it, you end up with a very high dose. That increases the risk of overdosing, and that increases the risk of addiction. Overdosing, because tolerance in the breathing center does not occur as rapidly as tolerance to reward or to analgesia. And so this complacency in terms of the belief that opioids were safe led to an overprescription of opioid medications that actually, right now, we, at the United States, actually consume something like 80 or 85% of all of the opioids in the world. And there have been many statistics trying to quantify. We provide sufficient prescriptions of opioids right now to be able to treat every single American in the United States, whether they have pain or not, for 3 weeks daily with opioid doses. So we are overprescribing. We overprescribe. And that led to diversion, that led to abuse, and it also led in patients like the story we just heard that actually did not have an addiction problem ever, that had pain, to become addicted, and in other instances, even if they don't become addicted, to overdosing, because you just have to escalate the doses. And this led to what we're seeing here, 1999, 2015. And the colors there is the temperature color scale, and shows the areas in red where you have the highest levels of mortality. So these are normalized for the population of each region. And you can see that whereas in 1999, there were only 2 areas with the high rates of overdose deaths, corresponding to a West Virginia, Appalachian region, and then a little area in New Mexico. Now look at 2015. The whole country is being devastated by the number of people dying from overdoses of all ethnicities, of all ages and demographics. So here it is. This is what caused really the initiation of this opioid crisis, the increases in prescription opioids. And so that, you see, opioid prescription from 1991 to 2011 for 2 classes, hydrocodone and oxycodone, just 2 classes of them. And you can see just for these 2 classes, there were 220 million prescriptions of opioid medication 2011. 290 million. And I will say, I mean, are we a nation in such levels of pain? Obviously not. These are improper prescription practices. And how that relates into the differences in males and females. And that was very interesting in my brain, because what surprised me, if you look at, and I took it away because you are going to see the slide later on in the next presentation. If you look at the number of deaths between males and females from the prescription opioids, we saw that the rate of increases of fatalities was much greater among women than males. And the other thing that was notable in my brain, it was in women that were 45 to 54 years of age. And that's not the demographic that you normally associate with abuse of drugs, which clearly led me to realize that part of the problems are associated with the prescription practices that we have for managing pain. And women are much more likely to be prescribed opioids than men. And this data shows it there. And these differences in the prescription of our opioids is one of the reasons why we're seeing right now that the demographics in terms of prevalence are actually similar in men than in females, which is a very unusual state of affair as it relates to substance use disorders, where it's basically not the case for other drugs. We become aware that this overprescription of opioids cannot continue and that we need to start to decrease it, that it's not justified for clinical need, and it is fueling the opioid crisis. So since 2011, we've seen very aggressive campaigns to try to actually decrease the amount of prescription and opioid doses that are being given in our country. And we've succeeded to a certain extent. And I said to a certain extent, because this is the data where we have 2010 to 2015, 15% reductions. And this reflects for morphine milligram equivalents. So that's in the good direction. But I would put forward that is far from being sufficient. That is a massive amount of opioids that we're still prescribing in our country. But at least it's going into the right direction. So we were all very excited about the notion these practices, therefore, we should start to see also the rate of opioid deaths going in the same direction, started to go down. So when the CDC reported the 2015 data, in which they indicated that no, they are not going down, but that they actually are going up. And that actually was also very clear, of course, in 2014, and it's repeated in 2015, and it appears that it's also going to repeat in 2016 when we get the data, was very disappointing, but it led us to try to understand what is happening. Why, despite all of these efforts, even are we not just not able to bring it down or stabilize, but it's actually going up, and it's going up actually quite rapidly. So if you look at what's happening, you realize that now the opioid prescription epidemic, people that are becoming addicted to opioid prescriptions, we don't know what percentage, 4 to 6%, transitions into heroin. Why? Because heroin is cheaper and more accessible. And even though it's only 4 to 6%, the enormous amount of people that are becoming addicted to opioid prescription brings up actually a fairly large effect. So that 80% of the new heroin users in our country are started by taking prescription opioids. And this actually is leading what we're seeing right now. Increases in fatalities, so we're seeing continued sort of a little bit stabilized overdoses from prescription opioids, but significant increases in heroin fatalities, which had not happened in years in this country. They were very, very stable for 20 years. So what was injection drug use? Now that's going up with all of these devastating consequences. And also something that we had not seen at this level ever, and it's a big, big challenge in many levels, is the emergence of synthetic opioids. And what are synthetic opioids? Well, heroin actually is something that you extract from a plant, so you have to cultivate it. And synthetics are drugs that you do chemically and you can manipulate in order to actually have extraordinary high potency. And chemists are very, very clever, so they develop syntheses that are relatively easy. And this has resulted in an enormous amount of interest from the perspective of a drug dealer, because you have very potent products that are easy to manufacture and that are easy to bring into the country, because these drugs are so potent that you need very little volumes. So what we are observing across the country is heroin, which was actually also the potency, the purity of the heroin has gone up, the price has gone down, is now being laced with fentanyl. And this is very, very notable in the whole northern eastern part of the United States, New Hampshire, Massachusetts, Philadelphia, in which actually, which is very devastating, because these are, in some of these states, because of the fentanyl, you have seen doubling or tripling of the fatalities over a couple of years. So these fentanyl and illicit opioids are extraordinarily risky as it relates to overdoses. So that's what's generating the very steep increases in opioid fatalities, and you can see there synthetic opioids. Now, what is it? How does that relate to women and men? And look at the changing face of heroin use in the United States. I said more women are being prescribed opioids, more women are becoming addicted to the prescription opioids. And since that is what's driving the prescription opioids, the new epidemic, what we see that in the past, most of the heroin cases were male. Now, with time, what we're observing is that there are no differences on the 2010s between the prevalence of heroin use between men and women. And again, I want to emphasize the heroin that we currently have is actually of very high purity, which is one of the reasons why we're also seeing very significant increases in mortality with its use. And then as it relates to natural and semi-synthetic opioids, you can actually start to see how the fatalities in terms of overdoses from opioids are equating for men and women. And again, highlighting this is very, very unusual as it relates to any drug of abuse. So what is it that we can do as an agency? I represent an agency that does science, that does research in order to use knowledge to come up with solutions. So in an analysis, it's clear that that we need a multi-pronged approach from the perspective of science. And one of them we've been highlighting is the need to actually address the need for better treatments for pain management, because patients suffering from chronic pain, which is actually in many ways much more complex than addressing acute pain, which is why I'm not going to speak about it. Chronic pain can be extraordinarily challenging. And the reality is that we don't have many alternatives for the management of chronic pain. There are some medications, but their efficacy is quite limited, and many of them do have side effects. So the challenges come from the perspective of the need of investment on non-opioid medications or opioids that are non-addictive and have less side effects to manage pain. We need to do it. And this is an area where the pharmaceutical has stopped doing research and development because they have failed so badly in the past. We need to re-energize it. And so this is one of our priorities. And the other two priorities is we need to actually address treatments for people that become addicted to opioids so that they don't transition to heroin. And if they transition to heroin, we can actually lead them to better outcomes. And importantly, we need to develop treatments not just to revert opioid overdoses, but to prevent them, which is, again, one of the big challenges that we're observing right now. So how does this relate to men and women? Women are more sensitive to pain. And this is actually whether you do it in a laboratory environment, or you look at it like this data that came from the National Academy of Medicine report on pain in the United States through epidemiological studies. The prevalence rates of some of these chronic pain conditions are higher in women than males. And so you hear it, for example, the prevalence of severe headache or migraine is much higher in females than it is in men. And so the females are in the darker blue than the males. And low back pain and neck pain are higher for women than it is for men. Now, why is that so? And again, I'm just going to basically say the obvious. We are biologically different than males. I mean, females are not the same as a male. We have many things that correspond, but I'm going to just highlight. So if you produce inflammatory pain, what you see, and this is what the data to the left is, and these animal experiments, is that the female brain mounts a much stronger inflammatory response than the male brain. And this is important because inflammation is one of the mechanisms by which you generate chronic pain. So this is an example how dramatically, there you see it in pink, and the females, and blue are the males. You can see that significant differences in responses. The endogenous opioid system that I show you, one of the targets is the mu-opioid receptor system. There are other targets. The mu-opioid receptor system produces reward, sense of well-being, analgesia. The levels of those receptors tend to be lower in females than in males. But there's another side to the opioid system, receptor system, the kappa receptor system. And when the kappa receptor system gets activated, you actually have dysphoria. It is very, very aversive. And in chronic pain, that system gets activated. But in normal, just you and me, if you don't have chronic pain, if you were to actually compare our brains, and you compare me as a female versus you as a male, you can see that the significant differences in the kappa receptor signaling. It appears that females have a greater activation, which is why you see decreases in binding of the ligand of that system. And therefore, this could be one of the mechanisms by why women are much more likely to experience pain in a more distressful way than a male. Well, and the way that you respond to pain actually, of course, could be one of the mechanisms that puts them at higher risk for chronic pain. So our endogenous opioid system, which is fundamental in our way that we actually address internally pain, differs between males and females. As it relates to the treatment, opioid use disorder treatment, we have treatments. We have methadone, buprenorphine, Vivitrol, and they work. They work for many, many, many purposes. Actually, it decreases drug use, it prevents overdoses, it prevents infections, it improves neonatal abstinence syndrome. Every single indicator has been shown to be significantly improved by these medications. But they are not being widely used. And actually, even when they are used, they are actually not used in a way that they sustain the chronic-based model of addiction. And so it's used for a couple of months and then it's stopped. That doesn't really work very well at all. So what is it that we need to do, and what are the challenges, and what are the challenges and unique things for women? I would put to say that one of the things that we need to concentrate also as a consequence of this opioid crisis is neonatal abstinence syndrome. Women get pregnant, women have babies. And what is shocking is in all of these prescription practices, we now know that 17 to 19% of women in the United States who are pregnant receive an opioid medication. So changing practices there is a very important one. But these babies that are born, actually, when a woman is taking opioids throughout, will have an abstinence syndrome. And if not treated properly and severe, the baby can die or have adverse outcomes. So there we need to actually figure out treatments, and this is an area that we develop in terms of research. What are the best treatment models that we can offer a woman that's pregnant who has an opioid use disorder, and what are the best treatment interventions that we can do to a neonate that is born with abstinence? And in this case, for example, this is a study that was just very recently published, shows that using buprenorphine significantly in the baby significantly improves the outcomes as opposed to using morphine. So there are multiple places where we can work. And one of the areas that I want to emphasize is that the continuity of care, that we need to look at addiction as a chronic disease model. So once the mother is released with the baby, she's still addicted. So we need to ensure that she will have proper treatment so that her outcomes are going to be good, because that's necessary for the outcomes of the baby to actually be good. We need to develop models that expand access to these medications, whether it's males or females. There's not sufficient treatment programs in the country to address the needs that we currently have. So we've actually engaged with the healthcare system. The healthcare system in general has said, no, addiction is not our responsibility. Well, it is their responsibility, and so much more now that it is a cost of the healthcare system. So we are engaging networks with different specialties. This is an example on a study done with emergency departments. Emergency doctors are seeing the patient with an overdose, and what you hear is that they are being released into the street with no treatment. That's malpractice. Well, nobody seems to be even noticing that that's malpractice. The patient comes back or dies. So there are interventions that we can do to prevent that. And similarly, there are interventions that we can do to maximize our resources and infrastructure, primary care physicians. We were discussing the notion of anesthesiologists, infectious disease physicians. There are multiple specialties that could engage and help us address the needs of patients suffering from an opioid use disorder. We're also working, and again, one of the main initiatives right now at the NIH is to try to generate a public-private partnership that can help us re-energize the need of medications for the treatment of opioid use disorder, for preventing overdoses, and for the better treatment of pain. And finally, I want to end up with this slide because there are many things that we can do into the future, and research is ongoing, and some of the products may come up relatively rapidly. But I think that we can do immediately and profoundly change the outcomes is education. And we need to address the needs of education of those in the healthcare system, whether they are physicians or nurses or pharmacists, in terms of their training for screening and treatment of pain, and recognizing how to properly prescribe opioids if the patient does need them, but also, on the other hand, training them on substance use disorder so that they can recognize when their patient is a high risk for becoming addicted, and very importantly, so that they can recognize when their patient, herself or himself, is becoming addicted and can intervene. Thanks very much for your attention.
Thank you so much, Dr. Volkoff. You can see why we've invited her multiple times. We appreciate all that you and your team at NIDA are doing, and we are very excited about the new research initiative and feel that you all are doing incredibly important work. Our other presenter today is Dr. Jerome Adams, who was just nominated to serve as the next Surgeon General of the United States. And Congresswoman Susan Brooks will introduce him. Congresswoman Brooks is the Republican co-chair of the Congressional Caucus for Women's Issues and is serving her third term representing the 5th District of Indiana. She chairs the Ethics Committee and is a member of the Energy and Commerce Health Subcommittee, so has been very intimately involved in this issue in committee, but also is the sponsor of several healthcare bills, including legislation to prevent prescription opioid abuse, which became law last year as part of the Comprehensive Addiction and Recovery Act.
Believe it or not, I just came from an oversight hearing on opioids that Energy and Commerce is having. The oversight, Dr. Tim Murphy, and we had state representatives from Maryland, Virginia, Rhode Island, and Kentucky just present to us. And so if you want to hear what's happening in the states, actually check out the hearing that we actually just finished a little bit ago. It is truly my pleasure and honor, and you really are in for a treat, and the fact that you are all here is so critically important. The fact that you got to hear from this expert from NIH, so critically important. She is the leading expert in the country on this issue, and so very happy to see you again, Dr. Volkow. But then from the local level, soon to be hopefully at the national level, my good friend, a fellow Hoosier, and actually a constituent, which is really nice, and a nominee to be our next Surgeon General, Dr. Jerome Adams. And I just want to tell you very briefly what experience he brings here to the discussion you're about to hear. He was appointed state health commissioner under then Governor Mike Pence and continued on under our new governor, Eric Holcomb, and he has played a critical role in our state's response to the heroin and opioid epidemic. A few years ago, very sadly, Indiana made national and, in fact, international headlines because we had a massive HIV outbreak in a very small rural county in southern Indiana, Scott County. Previously, they had maybe had 3 HIV cases a year for a number of years, and in 2015, that number jumped to 200 cases, and then beyond. We were actually the international epicenter of the HIV crisis. More HIV cases per capita in a small rural county than anywhere in the world. Not a good thing to have happen, not just for the citizens, but and it came from addiction, quite frankly. This came from the heroin and the opioid drug addiction through the needles and through the interaction with the individuals in that county. Now, let me just tell you, the one drug that they were also incredibly hooked on is called Opana. Opana. Just this week, very pleased to share that the FDA requested of that pharmaceutical company to pull Opana, which had been a legitimately prescribed opioid, off the shelves, and that has happened this week. And I want to make this point because obviously there are legitimate, as you've just heard, and important pain medications. I won't ask, but my guess is if many of you have had some oral surgery, a foot surgery, any kind of surgery, you were given a bit of pain medication, which is critically important, and usually some form of opioid. But what these panelists are experts in is how that lawful prescription and prescribing of opioids intersects with then the issue of addiction, and it's very complex, as you've just seen. But we do need to get this right. We need to make sure that people do have access to pain medication. And that's been the difficult thing that our committee in Energy and Commerce in a bipartisan way under the CARA bill tried to make sure that we struck the right tone, not to remove all medications from people with pain, but to try to get it right. Dr. Adams has been at the forefront of this intersection. In fact, at the time that the the significant increase in Scott County was on the rise and getting the national attention, I'm in a meeting I convened with our state officials on it, He was appointed that very day. That was his first day on the job. Okay? And I remember, and I had known him previously because he was a prominent physician in one of our healthcare systems. And I said, welcome to your new job. And he has done an amazing job. So he has focused on getting our state legislators and other agencies focused on the comprehensive approach connected to those with substance abuse treatment. He's helped them access insurance. He's implemented an emergency needle exchange program, which was controversial, I might add. These are difficult, very difficult programs to explain and understand. Law enforcement was not in favor of it. But he has been able, because of his incredible background and expertise, to be a great public policy advocate for those with addictions. I just want to, he's originally from Maryland, but he grew up in a rural community, a lot like the communities he's been trying to help in Indiana. But then we were lucky he came to IU to med school, and he's been a Hoosier ever since. And so very pleased that he has recently, and I think appropriately so, just been nominated to be the Surgeon General of the United States. And so best of luck. Thank you. Thank you. Thank you. Thank you. So proud of you.
Well, good afternoon, everyone. Wow, I hope I live up to that wonderful introduction. Isn't she great? I want to thank Representatives Brooks, Frankel, Walters, and Lawrence for the opportunity and for doing this. It's ever so important. I want to thank Cindy and the Women's Congressional Policy Institute for holding this. And I also want to thank Dr. Volkow. You all really are very, very lucky today. Usually I'm about 100 yards that way in terms of how close I get to her when we're at meetings. Now, granted, there are meetings filled with nerds like me who are like, we eat this stuff up. I could listen to her all day long. But truly, truly, she is a giant in the field. And I'm very fortunate to be here with her today. You know, no matter who you talk to, you're likely to find someone who's been affected by the opioid epidemic. And I usually don't like to do this, but raise your hand if you know someone who's been affected by this opioid epidemic. Great, great, thank you. I think it's so important that folks recognize how pervasive this problem is. My own brother is incarcerated right now due to the fallout of his substance misuse throughout the years. It was not adequately recognized, adequately treated along the way. And whether it's your niece, your brother, or the little old lady next door, this is affecting people across the country of all stripes, and we really need to be more aware of what's going on at the state level. I am a practicing anesthesiologist. I'm also the Indiana State Health Commissioner, and from a policy point of view, one of the things I implore all of you all to do is reach out to your state officials, your state health commissioners, because you're here in DC crafting laws which I explain to my residents and students as mostly being big guardrails. But then it comes back to people such as me on the state level to determine how those laws are going to play out on the state level in your communities, in your districts. And so it's very important that you understand from them what the challenges they face are, what opportunities exist, and how you can help them really change what's going on. Because I'm from DC, I love DC. It's really easy to get here and lose sight of how the problem really looks like on the state level, on the local level. I'm going to give you all a view from Middle America. We're going to talk about the increased burden of the opioid epidemic, particularly in the Midwest. I'm going to talk a little bit about the Scott County HIV outbreak, because that is why I am infamous, not famous, but infamous. We're going to talk about significant concerns regarding neonatal abstinence syndrome, and Dr. V talked about that a little bit, and also infant mortality, an interesting new trend that we're seeing. And then finally, I'm going to finish by talking about the increased burden of on the Indiana Department of Child Services, and I suspect that this is the same for many other states, particularly in areas that have been particularly hard hit by the opioid epidemic. So this map here looks at the age-adjusted rate of overdoses in the United States. It's similar to the one that Dr. V showed. Indiana's rate is 19.5 per 100,000. We're ranked 17th nationwide. But what I want you to pay particular attention to is this area right here in that Appalachian belt. Now, when you look at painkiller prescribing, as Dr. V mentioned, we have an epidemic of overprescribing, and it is worse in certain areas. That yellow dot right there, that's Scott County, Indiana. It is not a coincidence that it is in the middle of all that purple. Those purple states are states that prescribe more than one painkiller prescription per person per year to all their citizens. The same map would also look similar if we were to superimpose hepatitis C rates. And most hepatitis C is transmitted by injection drug use. So if you leave here today with a certain number of points, takeaway points, one of them I hope is that you leave here recognizing that overprescribing equals harm. Overprescribing is happening. It's resulting in overdoses, hepatitis C, HIV, harm across the board, and we must work harder to address it. This slide shows an 894% increase in the rate of unintentional drug poisoning deaths in Indiana between 1999 and 2015. This unprecedented increase mirrored what's going on largely on the national scale, and again, largely due to prescription opioid misuse. This slide shows a 771% increase in the rate of unintentional poisoning deaths in Indiana between 2003 and 2015. But what I want you to take note of here is that right around 2005 or so, Indiana surpassed the U.S. And Indiana is similar to many other Midwest states, Kentucky, Ohio, Michigan. All of those states surpassed the national average right about that time in terms of drug poisoning deaths within our country and are still rising. We haven't hit our peak yet. We're still rising. As Dr. Valkow mentioned, prescription painkillers may affect women. Well, she gave you the evidence. They do affect women differently in different ways. They experience more pain, and research suggests that they may be sensitive to more pain. More likely to have chronic pain, be prescribed prescription painkillers, be given higher doses. We have to figure out why that is, because that's another factor which may correlate with your predisposition to going on to chronic pain and chronic opioid usage. Use them for longer periods of time than the men may be more likely to engage in doctor shopping. And this is from CDC work, and may become more dependent more quickly. So again, we need to make sure we're focusing on doing research to figure out why certain groups, and in this case we're talking about women, are predisposed to first experiencing pain, being prescribed opioids, and becoming dependent upon opioids. This is a diagram that Dr. Valkow mentioned earlier, and you can see the age distribution of overdose deaths in Indiana in 2015. Overdoses are responsible for a significant number of Hoosier lives lost during their prime parenting and productive years. So this whole panel is supposed to be focused on women and children. We're losing 25 to 34, 35 to 45-year-olds. The impact of opioids, I fear, may be similar to the impact of us having a world war. You're literally losing a generation of folks to the opioid epidemic in this country. And this chart here is just another way of looking at it. The incidence of drug poisoning deaths among women, as Dr. Valkow mentioned, increases with increasing age, and we need to figure out why and what the implications of that are. The red are women, and you can see that at about age, the incidence of opioid use in women continues to rise as they get older, whereas the incidence of drug poisoning in men decreases as they get older, to the point that at about age 64, 65, women surpass men in terms of drug poisoning deaths. So this epidemic looks different. You can't treat a problem if you can't properly diagnose the problem, and we need to understand that it looks different and it affects women differently than what it affects men, so our policy solutions need to account for that. Looking at drug deaths and heroin overdoses per year, notice in 2004 we had 0 opioid or heroin overdose deaths reported in Indiana in women. It has steadily risen, and in 2015 it is now up to 67 women who are affected. Non-fatal hospitalizations due to heroin by year in sex between 2009 and 2015. And again, this is consistent with the data provided by Dr. V. Percent increase for women, 282% increase in non-fatal hospitalizations due to heroin in women. And that's much higher than the increase for men, or significantly higher than the increase for men. Non-fatal overdoses, ED visits due to heroin by year in sex. And again, you can see a significantly higher percent increase in women, 621% increase in non-fatal emergency room visits due to heroin in women as compared to 473% for men. Too high for either group, granted, but we need to figure out why that difference is occurring, dig a little bit deeper into there. And given these alarming trends, it is no coincidence that Indiana was the location of the largest HIV outbreak related to injection drug use in United States history, as proclaimed by CDC Director Tom Frieden. We had a rural injection, a prescription opiate in a county, and as we all know, we traditionally think of opioid misuse as being urban, as being amongst people with brown or black skin. This was all white in a rural area, prescription opiates. We're now up to 209 confirmed HIV cases in a town that had never had more than 3 cases in a single year. 132 males, 87 females. Again, all white, significant poverty, unemployment, lack of education, lack of insurance. So we need to look at the environment that is around these folks and what's contributing to them being at higher risk for opioid misuse. 95% co-infected with hepatitis C. And I was on a National Institute's panel looking at the eradication of hepatitis C. That's another policy decision that you all need to grapple with as you're talking about policies moving forward. The cost of hepatitis C actually is likely to surpass by far the cost of HIV in this community when you look at 95% co-infection with hepatitis C. All report injection of the opioid analgesic oxymorphone or Opana. And another point I want to make, Dr. V showed you that prescriptions are decreasing, but overdoses are increasing. We're actually worried right now, while not on alert, in regards to Opana being pulled. And I testified at the FDA hearing in favor of changing what we're doing with Opana. So I helped lead to that being pulled. So I don't want you to feel like I'm saying this is a bad thing. It's just something you need to be aware of. As prescriptions go down, as the availability of prescription opioids go down, and as we continue to still have a lack of good treatment options out there for folks are going to transition over to heroin. They're going to transition over to fentanyl. And so while you're going to see the prescriptions go down, you are going to see the overdoses continue to go up for the foreseeable future. It doesn't mean it's a bad thing that the prescriptions are going down. It means that we need to make more addiction and recovery options available for folks. We need to make naloxone more available for folks so that we can save lives. We need to have programs that help folks transition into recovery when they do overdose. Another important point as it relates to women, this community was immediately next to a major highway truck stop. And I say that because there was a link between that truck stop and the spread of HIV. People would literally wake up in the morning, walk over to the truck stop, prostitute themselves, get a few dollars, come back and inject again. And then we had to worry about the complex interplay between HIV being spread through injection drug use and potentially through sexual transmission. Fortunately, we didn't have any HIV spread through sexual transmission, but there is a complex interplay between opioids and both the victimization of women and the easy money that women can get through trafficking, through prostitution, and how that feeds into the opioid epidemic and their habit. And so lots of opportunity there to partner with law enforcement and to not just arrest somebody because you're picking them up for prostitution, but maybe dig a little bit deeper and find out, are you prostituting yourself because you're trying to keep someone else's addiction fed? Or are you doing it because you're trying to keep your addiction fed? A lot to think about there. In Scott County, we also found that women were in many cases helping to perpetuate intergenerational drug use. Went to one house where there was a grandmother, a mother, and a daughter, all three in the same house injecting. Heard stories about mothers injecting their children as a way of calming and soothing their babies because they didn't know anything else to do. Or mothers having their children, teaching their children how to inject them to help them inject. And so we need to look at this complex interplay between women, families, and continued intergenerational opioid use. I do want to share some positive news. In Scott County, we've been successful in stemming the tide of the opioid epidemic. At the peak, we had 22 cases, new cases of HIV in 1 week. We're now down to a point where we go many weeks without any case, but when we do get a new case, it's one case. It's not 10 or 15 or 22. So we have been successful in Scott County. We also have 73% of folks virally suppressed, which means that their HIV levels are so low as to be undetectable, and they cannot transmit disease scientifically. That's using treatment as prevention of further spread of disease. CDC estimates that you'd normally expect 25 to 50% of people in a community virally suppressed. We are up to 73% in this rural town, resource poor. I tell you that because it proves that we can do it. we can reach folks. We have to take advantage of this. I think of every challenge as an opportunity. This opioid epidemic is a huge challenge, but it's also a huge opportunity for us to all come together and start talking about real policy solutions, real things that we can do to work together to try to educate folks and not just tackle the opioid epidemic, but health in general. I know that Secretary Price, his number one objective is the opioid epidemic. Our governor in Indiana, Governor Holcomb, his number one objective is the opioid epidemic. The President of the United States, his number one health objective is the opioid epidemic. We have a tremendous opportunity if we just grab a hold of it and use that opportunity to improve health for everyone instead of all just saying, woe is me, we're never going to dig out from this terrible problem. How did we do it? And I'm not going to go over this slide much, but I'm happy to answer questions. This slide is up here just to show you that it's not just one simple thing you can do. We had to do community building in Scott County. We had to build up resources. We had to do community education. I'm also from the same state where Ryan White was. And I talked to the health commissioner, who was the health commissioner during Ryan White days. And the same stigma, the same stories that you hear, the same fallacies, the same myths that you were hearing back in Ryan White days 25, 30 years ago, we were hearing again in Scott County in regards to HIV. So community education is important. Media and messaging is part of that. Syringe service program, as you heard about. One-stop shop, we had to make it convenient for folks to access these services. Addiction treatment, medical care, laboratory testing, having the CDC come in and help us with epidemiology, which is tracking down these cases and figuring out their contacts. All that was an important part of controlling this outbreak, and all those entities are going to be important in terms of controlling the opioid epidemic that's facing our country. This here is just to show you a CDC study. They did a county-level vulnerability assessment to having an outbreak similar to Scott County. I encourage all of you all to look up this study and find out which counties in your states are particularly vulnerable to a similar outbreak. So we saw in Scott County, one facet to the opioid epidemic is the effect it's having on rural and white communities. Indiana's also been focused over the past several years on our higher than average infant mortality rate. And you know, interestingly enough, despite doing better on most known predictors of infant mortality in our state and seeing a decline in our extremely high black infant mortality rates, Indiana and many other states across the country are actually seeing increases in white infant mortality rates. So let me say that to you again. We're doing everything that the scientists say we need to be doing as a state and as a country to lower our infant mortality rates, yet we're seeing our infant mortality rates go up. The question is why? And I would assert to you that it is an indicator of another effect of the opioid epidemic, not just neonatal abstinence syndrome, but infant mortality. When we review our infant mortality deaths in Indiana, we're finding more and more of those cases are in homes where someone was misusing a substance. And so safe sleep. Maybe they just weren't paying attention to the baby. Maybe they were co-sleeping with the baby and mom or dad shot up and rolled over on baby. All that goes into our infant mortality numbers, and it's something that you all need to be aware of on the state level. In 2014, the State Department of Health was charged with the Indiana General Assembly to determine the prevalence of neonatal abstinence syndrome through voluntary pilot programs with hospitals. I will tell you that on the state level, there is not a common definition of what is neonatal abstinence syndrome across the states. There is not a common practice of assessing women for risk factors for having a child who is exposed to substances. And so those are policy solutions that you should be talking to your state officials about. What we found and what studies consistently show is that you can have a significant increase in NICU stays with early identification and standard treatment of at-risk mothers and at-risk children. So this isn't just about doing the right thing, it's about saving money. Our hospital pilot findings, drug of choice depends on location, so it's important that you do surveillance. And what do I mean there? There were whole regions of our state where opioid misuse wasn't a problem, but cocaine use was really high. And then there were pockets where opioid use was really high. There were pockets where marijuana use was really high. But if you don't look, you will never know, and you may end up applying inappropriate policy solutions to populations that don't need those solutions while neglecting what they do need. Comorbidities can affect outcomes. There's a lack of treatment programs. There's interruptions in care when referrals are made. Our providers were saying to us, well, okay, now you're making us identify these moms. Now what? What do? We've got nowhere to refer them to. Support services needed during and after pregnancy. We seem to care a whole lot for moms and for babies, but what happens afterwards? Are we sending them home to an environment that's supportive? and we need to change the culture of providers and pregnant women. So what do our studies show? Well, as Dr. Volkow mentioned, cannabinoids are number one, but when you look at opiates, Indiana's positive rate for cord testing was 15.56%, almost 16%, almost twice the national rate of 8.5%, almost twice, and that's representative, again, I bet you, of a lot of states in the Midwest. Conversely, when you look at buprenorphine, and Dr. Volkow mentioned MAT, medication-assisted treatment, our rates of buprenorphine are much lower, almost a third of the national average, which shows that we need to increase the availability of medication-assisted treatment for pregnant mothers and for everyone throughout the Midwest. I want to close with talking about substance use disorders in our Department of Children and Families. Again, every state has something, they may call it a little bit differently, but a Department of Children and Families. We're finding that the opioid epidemic is affecting women and children beyond the newborn period. So our challenge is that an increased number of children and families have substance use disorders, many of whom are multi-substance users. I want you to pay attention to these numbers here. The number of children in need of services, we call them CHINs in Indiana. These are children who are receiving services, a lot of them being taken out of their homes, has increased from 13,000 in June 2012 to almost 24,000 in June 2017. We have almost 10,000 more people in the last 5 years who are at risk of being taken out of their homes, who are in need of additional services from their states. It's an 84% increase. If you look at this chart, almost 53% of children removed from homes in Indiana were removed for alcohol or substance use disorders indicated as one of the removal reasons. And I talked to our head of DCS just yesterday, and she said that's still an underestimate because they may get removed from the home for domestic violence, and that may be listed as the primary cause. And then they start digging a little bit deeper and find out, well, dad was misusing substances before he decided he was going to hit mom. So she estimates that up to 85% of their cases where children are removed from homes are due to substance misuse disorder. Remember when I talked to you about losing a whole generation? Think about a whole generation of kids who don't have a mom, don't have a dad, or taken away from their parents, or put in foster care, or put in the foster care system because of substance misuse disorder. We absolutely need to pay attention to this and figure out what to do. One of the other challenges, just so you know, when I talked to Director Bonaventura, who's our head of DCS, it's a real challenge because we know moms do better and kids do better if you can keep the family intact. And that's all well and good until you keep the family intact and something bad happens. And then everyone goes, well, why'd you let that kid stay in that home? You knew mom was using substances. You knew dad was using substances. How do we provide a supportive environment so we can keep that family intact in a way that still is safe for the child or the children who were in that home? So goals are earlier identification of and intervention in families who are at risk of substance use, expanding service options for youth and families experiencing substance use, supporting implementation of evidence-based practices and interventions for children and families with substance use disorders, contracting for specialized residential treatment services that enable mothers with substance use disorders to receive treatment while remaining with their young children. And again, I'm not part of the new administration yet, but I know FEMA, Burma, one of the things she is adamant about is trying to increase flexibility for states to be able to obtain waivers so that they can look at innovative ways to provide supportive environments for folks, including residential treatment programs, so that we aren't just saying, okay, well, you've got substance use disorder, have a nice day, and kick them out of the hospital because we have nowhere else to send them to, as Dr. Volkow mentioned. We want to contract for transitional housing programs for clients transitioning from residential treatment programs. So, A, it's having a place for them to go when they most need it. Do we have good programs? But then, how do we transition them back into society? Some of the saddest stories I hear are actually from people who got into treatment programs, and then they successfully complete their treatment programs, and then they go back home to the same house where everyone's injecting, and within no time at all, they're back into the same habits that they were in before, and we act surprised. Well, you send them back home to a place where everyone's injecting around them, all those same triggers, all those that same environment exists, and then we expect a different outcome. How do we look at this as a spectrum of chronic disease and put them in an environment that is supportive of them from diagnosis all the way through to recovery? And then we're expanding the sobriety treatment and recovery teams, or START model, to additional communities. This program combines a specially trained family case manager, a family mentor, and treatment coordinator to serve families where there are children under the age of 5 and the patient struggles with substance use disorder. So again, I talked about trying to keep that family intact, but keep them intact in a safe and meaningful way. So parting thought, surveillance is key. One of the things I commonly say is if you can't measure it, you can't move it. You have to know what's going on in your communities. Talk to your local health officers, talk to doctors in your communities as policymakers, find out what's really going on. Because the opioid epidemic, substance misuse, is not going to look the same in Rhode Island as it looks in Indiana, as it looks in Texas, as it looks in California. And it's not even going to look the same within pockets of your state. So you've got to know what's going on. More education. And Dr. V mentioned education of providers, which is critically important. I will tell you that we've got a long way to go in terms of educating our providers. Stigma exists within the provider, the physician, the nurse, the dentist, the physician assistant, the pharmacist community. We've still got stigma and a lack of education that we need to address. But also amongst policymakers and the public. When you talk about MAT, when you talk about syringe service programs, we need to have a frank conversation in our communities about whether or not these things can be beneficial, and have someone who can speak about the science so that we can reasonably balance the trade-offs that do have to happen when we're making these tough policy decisions on a local level. Talking about prescribing, harm reduction, naloxone is another place where there's stigma. It pains me to hear folks talk about, well, maybe we should just let folks die. Maybe we should stop responding to folks who have overdosed. What we need to do, I think, is focus on making sure we have a supportive environment so that the first or second or third time they overdose, we're putting them into services so that they're not going out into the same environment again. Another story I'll tell you, the best place for drug dealers to hang out? It's in the emergency room parking lot. Because someone goes in, they overdose, and we put them into acute withdrawal, and then there's nothing to do with them. So at 2 or 3 in the morning, you send them back out on the street, and not only are they in the same environment that they were in before, but they are in an acute withdrawal. We've literally given them a drug to remove all of the opioid from their system. And the first thing that they want to do, the only thing they can think about, is their next fix. And so we need to break that cycle. We need to focus on the needs of the medical community. We were just talking. Do you know what providers do? They do what's easy, and they do what they get paid for. So how do we structure a system to make the right choice the easy choice, and make the right choice the choice that providers get compensated for? Education to increase awareness of substance use and support for ongoing monitoring, referral, and treatment, and payment for folks to do the right thing. We need to continue to support expansion of recovery support services through state and local collaboration. It takes a village. I'm finding that out. Oh my gosh, I can't tell you the number of meetings I've sat in, and glad to sit in them, trying to bring together disparate partners, law enforcement, doctors, nurses, hospitals, policymakers, community members, public health departments. They all need to be on the same page. Consider universal screening of pregnant women to eliminate and or mitigate long-term developmental impact of NAS. And I hope you all pay attention to that, because now we're talking about our next generation. We need to deal with the problem right now, but when you start talking about NAS and infant mortality, you're talking about our next generation being lost. And then finally, remember the unique impact of the opioid epidemic on women and children and families. This is not a one-size-fits-all problem. There will not be a one-size-fits-all solution. There are broad policy strokes that we need to embrace, but we need to look at subsets of the population and make sure we're putting in interventions that will specifically help them, or else an entire generation will not only be affected, but may be lost for decades to come. So with that, I want to apologize because I think I may have gone over on my time, but I appreciate the opportunity to be here today, and certainly we welcome your questions.